the patient just has pure dead skin buildups. Even this wax has got a high composition of dead skin. So what is keratosis obturans? Now, keratosis obturans is a buildup of dead skin that's shedded from the ear canal but not migrated out. So our ear canal and the outermost membrane of the eardrum, the most lateral layer, so the eardrum is made up of 3 membranes. The medial the lateral layer, should I say, the one that's facing us, is made up of the same epithelial skin that lines the ear canal. The innermost membrane of the eardrum is the mucosa. So the mucosa is the same skin cells that's found in your nose, for example. So they secrete a bit of mucus, a bit of wet secretions on there. So it's a moisture type of skin. And the middle membrane is a fibrous connective tissue. That's what gives the eardrum its strength and rigidity. Now, as this skin sheds, it should naturally migrate out of the ear. That's how our ears have evolved over millennia. If it didn't, then everyone's ears would be full of dead skin, just like this patient. And everyone's ears would have the same particular issue. Now, so this skin normally migrates at a rate of about 3 millimeters a month. If you average out the ear canal, the average ear canal is 2.6, but let's just round it off to 3 centimeters. So it can take around 10 months for skin that dies on the eardrum to shed and migrate sideways out of the ear in a conveyor belt motion. So with keratosis obturans, what happens is the skin dies and sheds, but it doesn't migrate, and it collects into a plug of dead skin. Dead skin has got the same consistency as almost like a rubber ball. And this dead skin plug can enlarge and get bigger and bigger. The plug will get bigger and bigger, and it can start widening the ear canal. It can put so much compression against the medial part of the ear canal. So generally this happens deeper in the ear, in the medial part, so past the second bend near the eardrum, that it can start widening the bony part of the ear canal because of the compression. You can imagine just how painful that is for a patient. This patient wasn't actually experiencing any otalgia. So I think we just caught the keratosis obturans before it was going to become problematic. So we call this I'll call it a grade 0 if I'm honest. But you get different grades. There is no grade 0. I'm trying to create that one myself. So grade 1 is the mildest form of keratosis obturans. Well, you could classify this as grade 1, I suspect, but the patient didn't have any pain. So characteristic of keratosis obturans is a bit of pain and widening of the ear canal. So I wouldn't even say the patient's got a significant widenings, hence why I was calling it a grade 0, but if it had been left any longer, it would have been a grade 1. Grade 4 is the most serious. It can significantly widen the ear canal. You can get a lot of bleeding underneath the skin plug because it's compressed against the canal walls. When you remove it, there's like a lot of blood formation. Sometimes a grade 4, because it's so painful, would need to be surgically removed. And what we're doing here is, so this patient's got a narrow ear, which is even a bit more, it makes it a bit more problematic. But you can see with the endoscopic view, we can just see the whole ear canal. Now, a little tip for fellow clinical ear care specialists: the posterior, so the back part of the ear canal, lateral near the entrance. If you can just elevate this wax or skin, whatever it may be, off the posterior lateral canal wall, so just behind the posterior concha cartilage, there's a bit of a blind spot. You may not see it with an otoscope or microscope or head loops, but with an endoscope you do. You lift that off and it just facilitates the rest of the procedure. So you saw probably before I was working on the back part of the ear canal near the entrance, just lifting this plug of skin up out of this blind spot. So I've just put some olive oil drops on a couple of occasions throughout the procedure. You can see the fresher layer of skin on the outside. It's more white and light yellow. More to the centre, to the core of this skin plug. The skin has oxidised, it's died, it's been there longer, so it's turning more of a darker brown shade. And at this stage, the endoscope's not actually in the ear, it's just hovering at the entrance. I'm resting it against the tragus. And I've just got a fantastic view. Keratosis obturans, it's similar to a game of Jenga, I suspect. You pull one of the Jenga pieces and it suddenly all crumbles. So it's the same with keratosis obturans. You generally find that it's a bit of a struggle, but as soon as you remove a particular lump of dead skin or a particular strand or ribbon of dead skin, the pack of cards at the house of cards almost falls, and or like the Jenga pieces all collapse, and you just remove one piece It's the weak link of the plug of dead skin. Just makes the rest of the procedure easier to remove. So probably about half of it out. So I'm just trying to remove it here off the anterior, the front part of the ear canal. You can see the skin layer there, so I'm giving it a good wriggle and a tug. I'm at the base of the ear canal. You can see that fresher layer of dead skin forming, the whiter layer on the right where I am now, slightly older. It's more pale yellow. I'm really working this off the back part of the ear canal. It's really strongly adhered. The patient is really still, which always helps. So I'm rocking the suction tube up and down. You can see bringing this plug near the entrance. You can see the skin ribbons, it's all coiled. Dead skin is very elastic. It's got this spongy texture like a coil because of the ribbons, because they coil around each other. It's got a very bad, that's why I referred it to like a rubber ball earlier. A plug of dead skin in your ear, it's almost like a rubber ball. You can imagine that just getting bigger and wider. It's got a lot of kinetic energy, is past the word I was looking for. It's stored a lot of active energy. It's coming out much easier now. It's still quite a bit of a plug very deep in the ear, however. I think these gentle brushstroke movements. This is right up against the patient's eardrum now. It's the last plug. It's trapped in the inferior recess, so there's a little basin near the eardrum where you can get wax trapped or dead skin or even fluid, water. So I'm just trying to lift this out of the trench. So I'm suctioning upwards, and then once I get out of the trench, I'm rolling it down and then out of the ear. See all those ribbons of skin. So the occlusion's gone. Just a bit of dead keratin on the anterior canal wall and some near the eardrum. So I've just attached a fine end gauge. So just trying to get this near the eardrum first. That's in the anterior recess. There is some in the attic region, which I'll also remove in a moment. So there's the eardrum. It is visible. There is a light reflex. You can see the reflection of the light coming off the eardrum, kind of near the centre to the bottom slightly. That's always a good indicator of a healthy eardrum. Not always. Eardrum slightly opaque, slightly white. So we was an elderly patient. They generally have more opaque eardrums. It's just they're exposed to more acoustic vibrations over the years, so they do get a bit of scar tissue developing. See, just some wet keratin in the attic. So again, just using a fine end, just going to remove this nice and gently. There we are, and there's some on the posterior mid-canal wall as well, which I'm going to remove too.